Let me introduce my PhD thesis about investigations of influencing factors on the fit of ceramic restorations. My name is Adrienn and I'm a dentist at the Department of Prosthodontics. My supervisor is Yvette Roth and my SMS is Kata Kelemen. My vision is to offer patients the highest level of precision and accuracy in dental restorations, ensuring optimal oral health and satisfaction, and my mission is to deliver evidence-based recommendations to dental professionals. Here you can see my two ongoing projects, from which the first one is investigating the efficacy of different finish line designs on ceramic restorations. This will be a systematic review and a network meta-analysis. Ceramic crowns are extensively utilized in dentistry because of their outstanding aesthetic and excellent biocompatibility. The fit of this indirect restoration is increasingly important for long-time success. Biological failure of fixed prosthodontics is between 85 and 93%. Inadequate marginal and internal fit can lead to microleakage that can develop caries, that can lead to pulp infection and endodontic treatment, or gingival inflammation and periodontitis. The type of finish line design is the most critical factor affecting marginal adaptation. So one of the unmet needs in dentistry is to find the optimal finish line design that can preserve tooth structure and ensure the marginal integrity as well. So our aim is to investigating the different finish line designs on ceramic restorations. Our clinical question is there a difference between preparation designs regarding marginal and internal fit? Our population is the ceramic restorations, and we have 4 intervention and comparators: the chamfer, the rounded shoulder, the shoulder, and the vertical edge finish line. And our outcome is the marginal and the internal fit in micrometer. Our null hypothesis is there is no difference between the preparation designs regarding marginal and internal fit, and our clinical and research implication is to help clinicians to make a proper selection of finish line design for ceramic restorations and to educate students with evidence-based knowledge and practice. We have conducted our systematic search this December in 4 databases with the following search key. After the selection process, I have 47 eligible full text. All of our analyses are completed, but due to the lack of time, I will just present a few of them. So we have 3 main outcomes. The first one is the marginal gap, which is the perpendicular measurement from the internal surface of the restoration to the preparation butt at the margin. The absolute marginal discrepancy, which is the angular combination of the marginal gap and the extension error. And the internal gap, which is the perpendicular measurement between the axial wall of the prepared tooth and the inner surface of the produced restoration. The clinically acceptable range for the marginal gap is between 50 to 120 micrometer. For the internal gap is between 200 and 300 micrometer, and the suggested cement film thickness is between 50 to 100. So our first outcome is the marginal gap. On the top left corner, you can see our 4 preparation designs. So the orange circles represent the 4 designs. The size of the circles represent the numbers of the crowns that we have investigated. The lines represent the comparisons, and the numbers on the lines represent the numbers of the studies. We have 25 in vitro studies in this analysis, 21 two-armed and 4 multi-armed studies with more than 1,000 crowns. On the right corner, you can see our sucra plot. The higher the sucra value, or closer to 100, the more likelihood that the therapy is in the top rank or one of the top ranks. In this case, the rounded shoulder get the best results. On the bottom, you can see our leak heat plot, which contains the point estimates of relative effectiveness. If we compare the rounded shoulder with the other preparation designs, we can see that the mean difference is between 5 to 8 micrometer, which is clinically not highly relevant and statistically not significant. Our second outcome is the absolute marginal discrepancy. We have 8 in vitro studies with more than 300 crowns, and we can see that in this case the rounded shoulder also get the best results, and the mean differences are not clinically highly relevant and not statistically significant as well. And our third outcome is the internal gap. We have 12 in vitro studies with almost 400 crowns. And in this case, the more minimal invasive preparation designs, so the chamfer and the vertical preparations, get the best results. And if we compare the chamfer to the rounded shoulder, we can see that the mean difference is 30 micrometer, which is a statistically significant result. However, it's in the clinically acceptable range. So the strength of our study is that this is the first network meta-analysis about this topic with direct and indirect comparisons. These articles were included with the highest evidence and with a variety of outcomes. Our limitation is there's a high heterogeneity in the population, and only a few articles investigated the different interventions. So our main conclusion is that ceramic restorations with rounded shoulder finish lines exhibited the best marginal fit, absolute marginal discrepancy, and a clinically acceptable internal fit. However, all 4 finish lines produce marginal and internal adaptation with a range of clinically acceptable values. So these findings gathered from this network meta-analysis serve as an informative tool for dentists that all the finish line designs we investigated produce marginal and internal adaptation within clinically acceptable ranges. So dentists must choose the preparation designs regarding the clinical situations. However, we recommend a rounded shoulder finish line for ceramic restoration to achieve the best marginal fit and a clinically acceptable internal fit. The implication for research is that well-designed multi-arm studies are needed with direct comparisons of different preparation designs. Future studies need a standardized methodology with standardized measuring points and locations. And micro-CT is suggested for the future investigations because of high accuracy and spatial resolution. And we need a standardized and accurate threshold for the marginal and internal gaps as well. So you can see my first project progress. I finished my manuscript, and we would like to submit this paper this September to the Journal of Dentistry, which is a D1 journal. And my second topic is investigating the effect of wax butter manufacturing techniques on the fit of fixed restorations. As I mentioned, the main goal of the fixed restoration is the close adaptation of the crown to the prepared tooth. Metal ceramic and full ceramic crowns are the most commonly used materials for fabricating full coverage restoration. The first step to fabricate a pressed ceramic or a cast metal restoration is to make an anatomical wax pattern. Then we have to invest and burn out the wax to get the negative layout of this pattern. And then we either have to press the ceramic material or pour the metal alloy to this cavity to get the exactly same form. So the fabrication of the wax pattern is a critical step for long-time success. Conventionally, this wax pattern made manually by a dental technician. However, it has many human-related factors. But with the development of technology, there are different kinds of CAD/CAM manufacturing techniques, for example, the milling or the 3D printing. So we would like to see with which method we can achieve the best fit of the final restoration. So our aim is to investigating the different manufacturing techniques of wax pattern for fixed restoration. Our clinical question is there a difference between manufacturing techniques of wax pattern regarding marginal and internal fit? Our population is the wax pattern, and we have 3 intervention and comparator, the milled, the 3D printed, and the conventional manufacturing. And our outcome is the marginal and the internal fit in micrometer. We hypothesize that CAD/CAM manufacturing decreased the marginal and internal gap of fixed restorations, and this is our clinical and research implication to decrease this gap. We have conducted a systematic search this April, and I have done the duplicate removal, and I finished the title and abstract selection as well. And I would like to continue my work after my first submission. So to summarize my 2 ongoing projects, I would like to submit my first paper this September and my second one in January. Thank you very much for your attention, and let me finish with the words of Richard Dawkins, that science is the poetry of reality. Thank you.
Congratulations. I have a question. How does the internal fit affect the overall strength of the restorations?
Mm-hmm. So if there's a uniform cement film, so then then the occlusal forces can distribute in the occlusal surface of the restoration. So there are no high stress concentration that can lead to fracture or debonding. So this is why the internal fit and the internal space is important for us, especially in ceramic restorations.
Thank you.
Congratulations for your presentation. My question is about your first topic. You mentioned that a dentist should choose a preparation technique according to the clinical situation. What do you mean by that exactly?
Mm-hmm. So, for example, if patients have orthodontic problems or very small teeth, or for example in the front lower area, then maybe you can choose a more minimal invasive preparation to save the tooth structure, or in this case you don't have to do an endodontic treatment for them. So as we haven't got, as we saw that these preparation designs almost get the same results, then we can choose from them, or maybe we can mix them. For example, if there's a tilted teeth, we can use one of them in the lingual area and the other one in the buccal. So I mentioned that.
I see. Thank you.
Thank you.
I just have a suggestion that if students will come from other groups, maybe for easier to them to understand the preparation, if you put some pictures there.
It's true. Thank you. Thank you.
Congrats for your presentation and also for your progress. So I had a question regarding the second project, because it's not pretty clear for me that what type of preparations are there before they making these wax buttons, and the other one is what is the cast made of? So it's the cast is 3D printed or something like that, or other type of material. So is it homogeneous in the studies or heterogeneous?
Unfortunately not. There are different kinds of casts. There are some 3D printed, there are some metal casts where they pure, and there are some cases where they use natural teeth as well. So it makes high heterogeneity in the population as well.
Thanks.
I'm sorry if I didn't understand at the very beginning, but the first project was in vitro studies.
Yes.
Yeah, okay. Because that's, so in vitro I can prepare everything perfectly, which I want. It's just a matter of times and microscope, but in clinical situation it's different. And a lot of times we choose the chamfer instead of the shoulder preparation because it's easier to handle in the clinical situation. So I presume that the shoulder preparation is, if you do it very well, especially in vitro, the technicians can clearly see the margin comparing to the chamfer. However, it is very difficult to do it in the oral cavity, especially to make the impression perfectly.
It's absolutely true, yes.
So both the analog and digital. So maybe this should be discussed later. That
thank you. Thank you for
because the shoulder preparation. So this is one thing of the. And that was very wise that you said that the clinically not very relevant the differences, because in clinical situation I try to avoid make shoulder preparation because you lose a lot of teeth, and also we learned from trigonometry that if you have a triangle kind of margin, you can also during the fabrication process every error magnified 1/1 if you have a shoulder preparation, but only just 1/2 if you have any kind of angle like chamfer preparation or whatever. So this is very old this is just simple mathematics, but yeah, so that should be constant. And also before we say that which is the best and everybody go back to the vertical preparation, don't forget the periodontology part. So that's the reason of doing chamfer preparation or shoulder preparation, due to the periodontal reason. And this should be discussed before we say that, okay, everybody can just do vertical prep.
Okay, thank you very much for your suggestion.